I'm Dr. Daniel Kantor with MS World. I'm joined here by a great friend of MS World, Dr. Doug Jeffery, who is the director of the MS Center at Lake Norman Neurology at Piedmont Healthcare. Doug, tell me, you have a poster here that you're standing in front of, which means that you're presenting to people, because people back home want to know what happens in a scientific conference.
Absolutely.
Tell me a little bit about the poster and what happens in a conference when you present information.
Okay, so a conference is a great exchange of information. It's people who've undertaken individual scientific studies to try to learn more about the disease process and about how to treat it and about what to do and what type of factors predict subsequent disability progression. So this is an analysis from the FREEDOMS trial where we took patients with the greatest amount of brain volume loss over 2 years. And what we were able to demonstrate is that over the patients with the most brain volume loss at 2 years had greater disability progression at 2 years and greater disability progression at 4 years, and they were also far more likely to reach an EDSS of 6 compared to some of the patients who had less brain volume loss. In this edition, or this analysis of the data, we went back and we looked at the influence of baseline gadolinium-enhancing lesion frequency, age under 40 versus over 40, sex, male versus female, to determine whether or not there were any significant interactions. And we found a few, but the real crux of the issue was that the patients who lost brain volume loss were really the patients who lost brain volume were really the patients who did the worst. And the baseline predicted the loss over 2 years, and the loss over 2 years predicted disability progression out to 4 years.
I think that's what we're hearing a lot of. We heard Professor Kapos talk about NIDA for no evidence of disease activity and the idea of adding brain volume into that. But are we ready for prime time? Is an individual person with MS sitting at home ready to go to their doctor and say, what's my brain volume loss?
So they're ready for NIDA 3, no evidence of disease activity, using 3 measures, but not NIDA 4, because NIDA 4 is just too hard. So what we're trying to accomplish in patients with MS is the complete suppression of relapses, the complete suppression of new MRI lesions, and the complete prevention of disability progression. I think that's a very relevant clinical outcome, and that's what we're trying to do in clinical practice.
Now, I'm going to ask you a question I've asked other people. There's these 2 schools of thought in MS. One is start out low and kind of start slow, start with the safest, oldest options, and then build up if there's a problem. The other school of thought is to be aggressive from the beginning. Where do you fall on that? Okay,
so I'm in the very aggressive group, so my feeling is that I don't want to see anything go wrong. I want the patient to be as good now as they are when they're 90 as they are when they're now. So I think about it like this. If I have a drug which is highly effective, in which there's no significant risk, why would I ever use anything less effective? I don't want anything to ever happen to that patient. So that's really the way I look at it. And you always have to measure the risk-benefit, and that always plays into it. But if the risk is low, you want the most effective therapy by far.
Well, I'm so glad to hear your insights, and actually I think it's time for us to start having a real community discussion, not just us MS doctors, but the MS community overall as a patient community, and say, where are we? Why do rheumatologists take rheumatoid arthritis more seriously than neurologists take multiple sclerosis that affects the brain?
Yeah, that's because most neurologists, it's such a long-term disease that most neurologists really aren't thinking that 30 years from now, that young healthy woman is going to look terrible unless he intervenes in the appropriate fashion.
Well, Dr. Jeffery, thank you so much for joining us, and thank you for joining us at home.